You may wonder, where are the autoimmune rheumatological diseases? Is it because these conditions are rare, or are clinicians missing clues when patients present with vague symptoms? In this reflection, you'll understand how serological investigations can help contextualize a patient's presentation, allowing you to make informed decisions about patient care. Additionally, as a primary care clinician, you will frequently be tasked with filing these serological test results requested by other clinicians. If you believe this is an unmet need, then watch until the end, and I will review the use of serological investigations in rheumatological diseases in primary care. There are about 7 rheumatological syndromes to consider when you think a patient's illness may be autoimmune mediated. Let's start with SLE. SLE is a multi-system autoimmune disease that can affect the skin, kidneys, brain, and more. SLE, though less prevalent than rheumatoid arthritis in primary care, can be more complex diagnostically due to its diverse and often subtle systemic presentations. Typical symptoms include flitting arthralgia and early morning stiffness. There's also fatigue, Raynaud's phenomenon, and skin rash. Most patients, unfortunately, go on to have additional features of major organ involvement. For example, the kidneys might show blood and protein in the urine. Then there's pleurisy affecting the lungs, cardiac issues like pericarditis, and central nervous system problems such as headaches, cognitive impairment, stroke, and peripheral neuropathy. There are also hematological issues like anemia, mild lymphopenia, mild thrombocytopenia, reactive lymphadenopathy, and even splenomegaly. The onset of SLE is commonly seen in individuals in their 20s and 30s. Interestingly, it affects women much more than men, with a ratio of 9:1. Moreover, Afro-Caribbean and Asian females are more susceptible compared to European women. SLE, when present, has a positive anti-nuclear antibody test 90 to 100% of the time. Like SLE, other lupus overlap disorders may also have a positive anti-nuclear antibody, or ANA, test. We'll look at their characteristics next. Salient points about rheumatoid arthritis, or RA. It shares some features with other conditions like joint pain, swelling, and fatigue. However, there's a key distinction to be aware of. RA tends to cause more joint deformities, whereas systemic lupus erythematosus, or SLE, affects multiple organ systems. In Sjögren syndrome, shared features include dry eyes, dry mouth, and fatigue. One distinction is that Sjögren syndrome primarily affects exocrine glands, especially the salivary and lacrimal glands, leading to dry eyes and dry mouth. SLE, on the other hand, is a systemic disease that can affect nearly any organ system. Both disease patterns can coexist. Systemic sclerosis, also known as Scleroderma, has a prevalence of 1 in 10,000. Shared features include Raynaud's phenomenon, skin thickening like on the palms, and gastrointestinal issues as part of Crest syndrome. A key distinction is the more prominent skin and vascular changes in Scleroderma. Polymyositis and Dermatomyositis. Shared features are muscle weakness and inflammation. The distinction here is that these primarily affect muscles and sometimes the skin, such as with Gautron's papules. They also present with elevated serum skeletal muscle enzymes, usually 5 to 20 times the normal level. Mixed connective tissue disease, or MCTD, is a distinct syndrome that includes features of lupus, scleroderma, and polymyositis. It is characterized by high levels of anti-RNP antibodies. Fatigue and muscle pain are common symptoms that patients present with in primary care. Other symptoms to be aware of include skin rashes, ulcers, arthralgia or joint pain, and joint deformities. Additionally, dry eyes, Raynaud's phenomenon, and other skin issues like telangiectasia or calcinosis are also notable. If you suspect an autoimmune rheumatological disease, consider checking if ANA is positive. If it's negative, it's less likely that SLE or any other autoimmune rheumatic disease would be the cause of the symptoms. However, bear in mind, there are seronegative rheumatological syndromes. If a patient displays sufficient symptoms, consider referring them to a rheumatologist, even if the ANA result is negative. ANA-negative lupus is rare but has been documented. If you feel the results are likely to be negative, it's important to say so and explain your reasoning to the patient. This helps in setting the right expectations and guiding further steps. A minimalist approach to investigation might include requesting a full blood count, urea and electrolytes, liver function tests, glucose, creatine kinase, though a normal CK does not exclude myositis, thyroid function tests, C-reactive protein, myeloma screen in individuals over 50, anti-nuclear antibodies, rheumatoid factor, and a chest X-ray if the patient is a smoker, as paraneoplastic features of lung cancers can cause myopathies in 10% of cases. When you suspect an autoimmune rheumatological disease such as systemic lupus erythematosus, Scleroderma, or Sjögren syndrome, request an ANA blood test alongside the routine investigations mentioned earlier. If the ANA is positive at a dilution greater than 1 to 80, proceed to characterize antibody specificity. 2 follow-up tests are advised: anti-DNA antibodies often used to confirm SLE and anti-ENA antibodies which are associated with various connective tissue diseases like Sjögren's and mixed connective tissue disease. If ANA is negative, the likelihood of systemic lupus is less than 1%, and no further testing for anti-DNA or ENA, which stands for extractable nuclear antigens, is recommended. The lab would also report on what type of nucleus staining pattern was visualized on fluorescent microscopy. This fluorescent picture is produced when cultured human epithelial cells, also known as HEP2 cells, are incubated with a patient's serum, which contains the autoantibodies that you want to detect. The patient's IgG antibodies would react to the antigens of the HEP2 nucleus antigen. This reaction is then detected by tagging the HEP2 antigen patient antibody complex with another antibody conjugate that contains a fluorochrome tag, which is now visible under a microscope. There are 5 staining patterns to remember. The homogeneous diffuse pattern appears as a uniform, smooth staining of the entire nucleus. This pattern is often associated with systemic lupus erythematosus, especially when antibodies to double-stranded DNA or histones are present. These are the main contents of the nucleus. This staining pattern indicates a classic lupus presentation, and it is particularly useful in newly presenting cases. The speckled pattern appearance is characterized by a grainy speckled fluorescence throughout the nucleus. It's the most nonspecific pattern and can be seen in conditions like systemic lupus erythematosus, Sjögren syndrome, mixed connective tissue disease, and systemic sclerosis. Now, why does this matter? Well, around 20 to 30% of healthy adults have detectable ANA antibodies, and the presence of speckled staining doesn't automatically mean they have an autoimmune disease. The nucleolar pattern appearance shows bright staining around the nucleoli, which are the inner spots in the nucleus. This pattern is strongly associated with systemic sclerosis, particularly the diffuse cutaneous form. Why is this important? It can help distinguish systemic sclerosis from other rheumatologic conditions early on. Be sure to check for anti-centromere, anti-scale 70, and anti-RNA antibodies. The centromere pattern appearance features discrete dot-like speckles, often 30 to 60, corresponding to centromeres. This pattern is common in limited cutaneous systemic sclerosis, also known as CREST syndrome. Why does it matter? It's a highly specific pattern that can predict disease subtype and progression risk. In a cytoplasmic pattern staining appearance, there is fluorescence outside the nucleus, in the cytoplasm. This pattern points to antibodies against tRNA synthetases, often seen in polymyositis, dermatomyositis, or overlap syndromes. Why does it matter? This pattern alerts clinicians to possible muscle or lung involvement not typical in classic ANA-positive conditions. Just a few comments about these tests. As previously mentioned, ANA is positive in normal people and in a wide range of inflammatory and infective disorders. Antibodies to double-stranded DNA are highly indicative of SLE. Extractable nuclear antigens are a group of saline extractable antigens known individually as Rho, La, Sim, and U1-RNP, which stands for uridine ribonucleoprotein. Rho, La, and Sim were named after the first patients in whom they were first characterized, Robert, Lane, and Smith. In conjunction with U1-RNP, these proteins are responsible for slicing and processing mRNA. Anti-ENA antibodies can be found in systemic lupus erythematosus and Sjögren's disease, while anti-RNP antibodies are found in systemic lupus erythematosus and mixed connective tissue disease. check anti-centromere and anti-topoisomerase, also known as CL70, if you are thinking of scleroderma. In conclusion, the prevalence of autoantibodies in autoimmune rheumatological disease is very limited after systemic lupus erythematosus markers are excluded. If a patient is significantly symptomatic, refer to rheumatology for further assessment. Thank you for watching. If you like my content, consider subscribing to the channel for more educational videos.